63-year-old man who has persistent atrial fibrillation. He's had 2 cardioversions before, and the first was he was held in sinus rhythm with amiodarone for some years, but then has regressed to atrial fibrillation again. So this is his first ablation, and what we've done is we've recorded some segments of the setup of the procedure, which I'm going to play you in a minute. And then while we've been waiting, we've done some ablation just to get rid of all the boring bits, because the audience have seen pulmonary vein isolation a number of times before. If we can show the CARTO screen, please, Fred. What you can see is that we've done a wide encirclement around the left pulmonary veins. We've been using the VisiTag software upgrade on CARTO, which means that I've put a manual scale so that the 300 gram seconds is in the sort of white and cream area, and over 400 is red. And so you can see that on the back.
Richard, maybe you can explain a little bit what does it mean. I don't know if everybody is familiar with VisiTag software for CARTO.
Yeah. And so essentially what we've told the system to do is to tell us, put a dot when our catheter has been in position with a sufficient force and a sufficient length of time to produce a force time integral of above 300 grams a second. So once it has been stable for more than 10 seconds with a force threshold of greater than 5 grams, it begins to then start measuring the force time integral. And the larger the force time integral, the greater the lesion. And I deliberately set this up so that I can put low force time integrals on the back wall, but then on the anterior wall and roof, I can put higher force time integrals. And I've gone round the left pulmonary veins, but I've deliberately left some gaps because I didn't want to isolate it quite yet. So I've left some gaps up here, but I suspect that even once I've closed off those gaps, the breakthrough, as it almost always is, will still be on this side here, because this lesion set that I've done here is on the appendage side of the vein. And I know that because if I put my catheter on this area and apply force, the force goes backwards. So I'm actually on this side of the ridge. If I put the catheter inside the vein and then try and apply force towards this point, as I move it forward, you'll see the force begin to point forwards. So now I'm on the other side of the ridge. So that's how you tell which side of the ridge you are. And I am very careful. I always go on this side of the ridge, and then I'll often find there's a little breakthrough just here where this tissue is particularly thick, where I need to touch up.
So is this your strategy, that you first go from appendigeal side of the ridge and then you go from inside, or how you do that routinely?
Yeah, so my routine strategy is to go on the appendage side, hoping that I isolate without going anywhere near the vein, but also aiming to capture any fractionated tissue or ganglionic pexi or ligament of Marshall tissue on this ridge here.
Yeah, so I think this is important, especially we believe in long-term persistent AFib. This is area where you have a lot of fractionation and probably also conduction. Even if you do mitral isthmus line, you have to finish sometimes within this area with a substantial effort, because it could be very thick area. The amount of tissue is very big, and there is Marshall vein sometimes quite big, so there is a lot of tissue that has to be ablated. And for paroxysmal atrial fibrillation, you do the same, or you do just isolation within the venous site of this anterior ridge?
So my approach for paroxysmal is exactly the same.
Exactly
the
the same.
Between paroxysmal and persistent is I'm going to extend the procedure if isolation of the vein doesn't terminate the AF.
So maybe how many people are familiar with this technology, this electromechanical robotic system? Can you show up hands? How many people? So one person is familiar. So maybe we can explain a little bit about how it works, because we just jumped into the case without any explanation.
Yeah, no, bear with me. bear with me. So I've done some of the right coronary vein isolation as well. But what I'm going to do now is show you some videos of the setup of the case, which I hope will explain what's been going on and what we're looking at here. So if you can show the video recordings now. The first video you can see is the sheath that we use to introduce the robots. This is a 14 French long sheath. We have two other wires in the vein. One is for a Mullins transeptal sheath, and one is for a reference or a CS catheter just below it. So they're all in the right leg. And even the smallest woman or person will take all of the sheaths in the right leg, so they don't have to have any sheaths in the left leg. That's the robot sheath coming into view here, and essentially what it is two sheaths, one inside the other, which the inside sheath is rotated by some cogs, which then deflect wires within the sheath and give it quite a wide range of movement. So here you can see me putting in the 14 French sheath, and then I'm going to show you the prep of the robot sheath. So just to remind you that we've got two sheaths, one inside the other, so we need to flush both of those sheaths with some side ports. Just fast forward a little bit to here we go. So here I am connecting it to the outer sheath. The flush port's just out of view, but you can see it dripping out of the end of the outer sheath there. And now I'm going to connect my second port to a flush, and I'm blocking the end so I can back flush the side arm, and I've just clipped that off, and then I'm allowing flush to come out of the end of the sheath. So that's the entire prep of the Hansen robotic sheath, so you can see it's very straightforward. The next step is just to put an ablation catheter up the sheath, because the ablation catheter will function in effect as a guide wire. So I'm just pushing a Smart Touch ablation catheter up the sheath. We missed that bit, so sorry that was cut off. Now we're going to the transeptal needle, which is a Endries needle. This has got a sharp and a blunt element to it. So if you look carefully, you can see that there's the blunt element of the needle, which is safe to expose in the heart. And then when I'm in the correct position, I will advance the sharp, like you can see there, which will make the puncture. The great thing about this is that you can shape the needle to any shape you want, and you're not dependent on the sheath to get you to the septum. So the next video we're going to show is, I think, so this is us doing the transeptal under echo guidance, so we hardly use any fluoroscopy, so we're going to skip through that. I have made a puncture with the transeptal needle, and now I've got the ablation catheter through the sheath, and we have just made some geometry of the right atrium. So I've recorded something of the coronary sinus, and I've tagged the His position, and now I'm using the ablation catheter to try and cross the septum next to the needle. Now I'm using the anatomical markers of the CS and the His, so I'm not using X-ray, but I'm also looking for knock on the mapping catheter where it's touching the metal of the transeptal needle, which, remember, is blunt. I've got the sharp bit inside. And here I am sliding it through alongside the transeptal needle, so that I am through the intraatrial septum and into the left atrium. So that was the LAO view. So we've now crossed the septum with both our needle and our ablation catheter. We're then putting our decapolar catheter up. You can see me manipulating it there. And what we're really going to be seeing is the CARTO view. So if we can just skip forward a bit. Now, please, Fred. Skip forward to the CARTO when we're recording the CARTO images. Here we go. So here you can see me manipulating the decapolar catheter in the right atrium. Now, the reason I recorded the geometry of the right atrium with the mapping catheter is it then creates a matrix so that you can see any catheter within the right atrium. So this is a barred decapolar catheter that I'm trying to get up the coronary sinus. You can see I've got a little bit of the coronary sinus on the right-hand view, the LAO view. You can see I'm stuck in the middle at the beginning of the CS, but I can't quite get up it. I'm moving around trying to find a route into the coronary sinus, and in just a second you'll see that I managed to twist my way up into the coronary sinus there. Now I've got my decapolar in the coronary sinus. And again, I'm being purely guided by CARTO. I'm not using X-ray at all. So then once we've done that, we can then pass the pulmonary vein catheter up the transeptal sheath, and I can see it crossing the intraatrial septum here, and then exiting the transeptal sheath, and I know it's exited because the pulmonary vein catheter becomes visible. My next task is to get that pulmonary vein catheter into the left lower pulmonary vein here, and I know it's the left lower because it's behind the coronary sinus in the left lateral position, which was the right hand view we saw there, and it is lateral in the left atrium. So now I've done a respiratory compensation, and I'm recording geometry of the left pulmonary veins. And Neil, our technician, is going to take off the right atrial view in a minute just to make life a little bit easier so we can see what's going on. My pulmonary vein catheter has gone into the left upper, so we've got a bit of the left upper and a bit of the left lower here. It's quite a big left upper with quite a lot of branches, so we can see that as we begin to show a bit more geometry there, the left upper has clearly an upper and lower branch on it, and then we see the left lower that the PV catheter's in now. So I'm just filling in that geometry. Once I've got the left pulmonary vein geometry, we're going to switch to a new geometry and then record the rest of the left atrium. So this is the rest of the left atrium. So these videos aren't edited, these are real time. We don't have the facilities to edit, so this is me trying to create a right atrial geometry now. And I'm just flicked into the right lower. If I pull back and turn clockwise, I can go into the right upper. And again, this is all fluoroscopy free.
Is there any question from the audience?
Yes.
There is one question, Richard.
Actually, I raised my hand not because I'm familiar, because I want to ask a question.
Yes.
I have two questions. First, what's the difference between stereotax and this technique? Second question, what's the advantages of this technique over our manual ablation and
Yes.
mapping? Because it looks a little bit tedious.
Okay, Richard, did you hear the questions?
Yeah.
What is difference between this system and stereotaxis, and what is difference between manual and this technique? So you can tell your part of or your view, and I can maybe comment from my point here, from my side. So you can start.
So question number one, what's the difference between this and stereotaxis? With the more energy you deliver and the more force you deliver, the better the lesions, the better your chance of success. The less force and less energy you deliver, the safer the procedure is, but the less chance of success.
In my opinion, the major advantage of this system, specifically for AFib ablation, on the other hand,
Joseph,
it's... Yeah, sorry.
Sorry to interrupt. While we're talking, I just want to point out that as predicted, I've completed the line. I've gone onto this area here, and you can see the vectors going up, so I'm on the lower vein side of this junction between the upper and lower vein and the ridge. If you look at the BARD, we can see a fairly fractionated signal here. So while you're talking, I'm just going to ablate either side of this and see whether we can isolate the vein at this point. So I'm going to be ablating with the vector going up and then switch the catheter over and have the vector going down.
Yeah, this is very important. Again, here you can achieve very good stability within this area with Hansen. And it's a very thick area usually because it's like triangle, like pyramid between a superior, inferior vein and appendage, and a lot of epicardial input from that area into the vein. So I think here you have to do from venous side, otherwise it's very difficult to get rid of this. We don't see very much the signals. Maybe if we can enlarge the screen with signals. Yeah.
Big signal.
That's great.
So I've done the lower side. I'm just going to try and get onto the upper vein side. So that's still the appendage because the vector's going back. So I want to go into the vein a little bit more and then pull the... Now you can see the vector's pointing forwards now, so I'm on the upper the vein side. And there you see the way it flicked off there? So you
Mhm.
can see I'm really very, very close to the edge of the vein there, so I'm not going to be ablating a significant different distance into the pulmonary vein. So I'll just try and get back onto that position while you talk, Jose.
That's also an advantage. Here you can hook the catheter in the ridge, like a few millimeters behind the ridge, and you can keep it there, which is very difficult sometimes with manual, or you slip out, so it takes some time to come back. Here you come back very easily without the need for using X-ray at all. So that's, in my opinion, one of the advantages. Of course, to prove that it's much better than if you are a very experienced manual operator is very difficult, and you would require a very large number of patients, because if you are manually skillful and you have 20 years experience handling catheters, you can do probably a very good job, but I still believe that there are some areas where you cannot do the same like with robotic. But to prove in a randomized fashion that this is significantly better, you would require a lot of patients because if you are experienced. If you are inexperienced, I think the advantage of that robotic system would be even higher because it will make a procedure standardized. So I always, let's say, compare this with flying with autopilot. This is kind of autopilot. So even if you are not very excellent pilot, you can safely land with current airplanes because everything is basically controlled more or less semi-automatically or automatically almost. There is one more question.
We're waiting for the microphone. Richard, it's Andre here. I've got a question. You mentioned that you dial up the Visitech at 300 for FTI gram second. What sort of range of force at each site do you get to achieve that FTI?
So on the roof, I would expect to see quite a variation in force because of respiratory movements. On the back wall, I would expect to see much less movement because the heart moves up and down rather than side to side. And I'm happy with anything above 5 grams, frankly.
From studies we've done with the other technology, Anderson's catheter that uses fiber optics, it came out that you should optimally have at least 10 grams and reach FTI about 400 to be able to produce probably a very good lesion. But of course, this is again some arbitrary figure that was obtained from a limited number of patients. But it's clear that the more the catheter is stable, the higher contact force, the better lesion. And if it's jumping or if it's moving with the respiratory movements, then it takes a bit longer to get a similar value.
Yeah. Can we take the question from the audience, please?
Okay. I'm still concerned about the issue of the carina, or staying on the ridge with if you don't have the Smart Touch. Not having a fluoro or not having an ice, would you still be comfortable that you're 100% on the carina, not falling into the appendage or not drawing back? I mean, this wouldn't give you that confidence, would it?
If you did not have Smart Touch, then when we lost Smart Touch for a while because of the loss of the catheter manufacturing, we found that what we learned from Smart Touch actually meant that we weren't as comfortable without it, but we could do pretty well without it. We've also got the IntelliSense feature, which I don't think is as good as Smart Touch, but the Hansen force sensing does give you some feedback as to where you're sitting and the force you're applying. But the force isn't the only story. So for example, here you can see I'm on the venous side. If I pull forward, the catheter doesn't move because it's stuck there. If I move the catheter back, it will swing off the ridge. So it tells me which side of the ridge I'm on, even if I'm not getting a force sensing from it. So Smart Touch is a real luxury, but it's not the only thing that you need to get that really careful definition of anatomy, particularly if you've got really fine control of the catheter position, as you do with the robot.
Yeah, and then also if you use this FAM mapping, or if you use NAVEX alternatively, because it can be used both, you have a relatively
And we
good
can then see the
representation of the
difference
ridge if you
between
pull back
manual
and it
robot.
slips
So we've
out
already
from the
talked
vein. So
about the
if
obvious
you do it
differences,
repeatedly,
like you're
you
in the back
know
of the lab,
exactly where
you're relaxed.
the ridge is. You can use alternatively also intracardiac echo to see exactly where you are. With what we use in our setup, but Smart Touch is very good because it tells you really that you are pressing to carina from that side or from that side. So, yeah.
But you cannot use it with the Hansen, right? The
Why?
ice.
Why? We use.
Manipulating. Well, just you keep it on one position and that's it,
Well,
right?
you can play with ice anyhow. It doesn't impair your ability to use ice, Hansen Medical, at all. It's a little bit more difficult sometimes to visualize certain part because it's metallic sheath, so you have more stuff in the septum, but otherwise, but there are ways how to avoid this. You can go to higher, or you can go even to coronary sinus with ice catheter.
You can see that signals are a lot less busy in the vein now.
We're getting close.
So you are doing something.
Richard, can I ask you about your lesions? They are very nicely sitting on the outside surface of the shell. My question is about the use of contact force information in generating your geometry. Because with Smart Touch, quite a lot of people are now doing a force cutout in terms of editing the geometry so that they don't push and make a bigger atrium than it ought to be. And quite often, if we do manual creation of geometry, manual famming, the shell will be bigger than the actual size. And when you put lesions, they are actually hidden, the 3D lesions are actually inside the shell. So do you want to comment about that? And what's your standard approach?
That's exactly what happened here, Andre. So you can see that the fan we created with the PV is bigger. And what I've done is I've added regions that you can't see to draw in there's the isolation.
Isolated. Yeah.
I've added lesions to draw the fan in to where the geometry truly is.
Yeah.
So you can't see the lesions because I'm using them just to pull in the fan.
Yeah.
I could show you them. Let's see if visualization is set up. So here you can see where I've added lesions manually just to pull the geometry in.
Yeah.
But I'm not looking at them. I'm not using them to really mark the lesions. It's the VisiTag that's telling me where I'm really doing the lesions.
Sure.
So this VisiTag is kind of smart tagging. Instead of having only some dots of the same size and same color, this has a meaning. Either if you have Smart Touch, you can use contact force and energy or time. If you don't have Smart Touch, you can still use time and energy to have proportional tagging. So depending on size and color, it will give you information that you applied enough or just a little. So even if you have isolation, you can still go around and visit those areas where you did apply less, and you can do some insurance applications, because sometimes the patient feels pain, or so you stop early and then you continue and you may not remember all these sites. So this is kind of proportional or smart tagging that gives you additional information, not only that you put dot that you ablated somewhere.
So now we've isolated, as I showed yesterday, I put the mapping catheter into the lower vein, and I'm pacing from that so that we can demonstrate we've isolated both veins together. So you can see there's pacing and capture of the primary vein, and when I switch off the pacing, the vein becomes silent. So I'm going to just nip next door and just switch the PV catheter to the right primary veins. If we go to the camera next door, you can see that actually what I've done is I've just simply put a plastic drape over everything so I don't have to re-scrub.
Yep.
And so I can just use the cathode to guide me across to the right veins, and I'm going to pop it into the right upper. Can I have a right lateral on the cathode, please? Neil, right lateral on the cathode, because I'm trying to get into the right pulmonary veins, please. Just going to get the sheath in to support me a little bit more. Have an AP, please, Neil.
So this is the main screen. You can put also your Carto or Navex map in this screen, or you can put ultrasound if you have it. You can have this IntelliSense. All graphs are in. It's like Pilot again, having all these controls in front of him or her. So the same applies here. So you basically work without any tactile feedback, relying on information from different sources. So the more sources of information you have and more reliable they are, the better for you and for the patient and for the procedure. So I think this marriage of Hansen with Carto and SmartTouch, for instance, that's, you have so many sources of information that it makes really procedure very standardized. And it's still, I think, the first step only. I truly believe that in the future, there will be more things to control let's say, accuracy of the procedure. Or if you have, for instance, instead of this mapping, which is virtual still, if you have some kind of 3D imaging that will give you really anatomical shell of your chamber of interest, then you can program, go to this area with this preset contact force, and you will just sit and press a button, and it will go like a welding machine to different spots. So you will be just controller, not operator. So I truly believe it will come one day, but it's still not yet ready for such application.
Hopefully not soon, Joseph, otherwise they couldn't justify your enormous salary.
But still, there has to be some guy who knows how to do it if something fails and if there is any problem. There is one more question.
In some patients, when you ablate around the pulmonary vein, at certain point, all potentials disappear. Of course, you know this. Do you have an explanation for this? At very special point, you find that all potentials disappear.
How you mean, during ablation?
Yes.
Oh, you mean if you reach isolation and there are some potentials?
No,
or?
sometimes when you are doing ablation around the lasso, at certain point, in spite of having potential all around the whole poles, at one point, all vanishes and they never recur.
I suggest that there's only one entry point into the vein. Yeah. There's only one entry point. Yeah. Because obviously the fascicle can be just one tiny fascicle that feeds into the whole vein. So I think that's probably the interpretation.
There is a tremendous variability from anatomical studies. I was part of one study, and we did analyze post-mortem, and these fibers are crisscrossing. So there might be still, although there is some sleeve around the whole circumference of the vein, the conduction could go preferentially only in one area. So even with few points, you can isolate the whole thing. But still, I believe now with data we have from clinical experience, we always do circumferential line, despite the fact that you have isolation after, let's say, ablating only 1/4 of the vein. Because if you leave visual gaps, they can reconduct, or conduction can occur because you have some muscle there. So I think it's much better strategy to do really this kind of circumferential ablation.
And in the very early data from Bordeaux in segmental osteoisolation, it also depends on your lasso position. So your lasso is quite far in, you can ablate in remote areas that are not early, and yet you get PV isolation.
No, I didn't mean segmental, I mean circumferential, but this happens sometimes incidentally.
Sure.
So my question was, what's the explanation? You have answered this. Thank you.
Yeah, thank you.
So Richard, what are you doing? I see that
So
it's slowing down again in superior vein. Yeah.
Yeah, so we've done what we would think would be a reasonable line. We've slowed it down quite a bit, and now I'm just moving my catheter around the inside of the vein, or the inside of the line, to just try and gauge where the weak part of this line is.
Can we
and I
see now
suspect
bigger screen from Carto, please? Okay, thank you. Are you always ablating on the right side, like circumferential, and not between them? Because we feel that there is plenty of space in between, so we practically always ablate in between to make one line, like separate superior inferior line. So
Well, it's this bit here, Joseph, isn't it? The bit where we just isolated. That junction between the right atrium and the left atrium. If you go wide of that, you can get continued conduction. If you just go in a little bit,
Yeah.
as you say, you can often find that you can isolate in exactly the way we've just done now. I don't tend to do an intravenous line because I fear going into the vein, but I will often do, as you say, and make that little nudge in between them just to disconnect, particularly where it might connect the right and the left atria.
Yep.
We're just going to do the pacing maneuver. I've got the catheter in the right lower now, and we're going to pace and see what the right, and you can see there's the right upper dissociated from the AF, so we've isolated the two together as a pair.
That's very nice. Richard, can you update us on your normal ablation parameters for your Wacker lines? I saw 30 watts being delivered, was it anteriorly mainly, and posterior
So I do 30
settings?
watts.
Yeah. So you use 30
Yes,
watts.
I do throughout, just simply because I keep forgetting to change the power. But I use the force time integral now to go softer on the back wall and harder on the front wall. Now that I've isolated all the veins, I'm going to just switch my PV catheter into the appendage, just to use that to then map the AF characteristics and get an idea of what's going on in the rest of the atrium now.
So what will be your strategy for this case after isolation of pulmonary veins? That's now we come to the crucial part, because we all probably agree that isolation is step one, and we don't agree each other what is the next if you do especially long-term persistent. So what is your strategy in general?
So I take a look at the activation sequence. And in this case, we can see that it's pretty organized. It's often distal to proximal. Interestingly, the PV seems to be slightly faster than the CS.
What is cycle length in appendage? Okay.
Neil, can you measure that for us?
The faster, the worse, of course.
Yeah, so I'm tempted to have, I think it's going to be somewhere around here that our primary driver is, and the first place I'd look is in this little area here, and sure enough we can see some fractionated potentials just on the junction between the roof and the appendage and the vein. So I'm going to ablate those because they're going relatively fast. I can also see some fractionation on the proximal
Can we see
electrode as
bigger
well.
screen with signals, please? Yeah, thank you.
The great thing about the Visitag is it forces you to be patient. So I've often found, particularly with a robot that moves around so quickly, that I've not been staying long enough on a particular spot. So the Visitag forces you to be honest and make sure you do a really robust lesion in the spots you are ablating in.
Any questions here or comments?
Nice proceed.
5.6 is the earliest electrode on the PV now, fairly consistently. If we put the map so that it's lined up with 5.6, so 5.6 is around here on the PV, and that's the left atrium here. You can see the map leads it.
Mm-hmm.
If I drag back, you see proximal's a bit earlier, and then it becomes difficult to differentiate between distal and proximal.
So it's in
just at this site here.
Bachmann's bundle area, basically, huh?
Yeah, yeah. And there's no clear proximal to distal or distal to proximal activation on the map. So I'm going to ablate here, thinking that this may also be an area where the AF is being driven from. If I could see consistently proximal to distal, I'd keep going this way on the map towards the septum. And there we go,
Sinus rhythm.
Wow. Very
So
interesting.
it was the activation that drove me to that site. And it's a bit cheaper than
Topera.
Can we see now the map to be able to localize exactly the spot? Bigger map,
Yeah.
please.
So we need your glasses, Richard,
Yeah.
to be able to see these rotors instead of having expensive mapping systems. Very impressive.
Yeah,
And
I
you
think
notice
if you
the
if you
congregation
if you use
participants on
what we call farmer's wisdom, and you observe phenomena, usually you see a lot of things. If you are only dependent on technology, you like that technology too much, you can just talk about technology, but you don't have such good success sometimes. Yeah?
Yeah, there's still a bit of old-fashioned electrophysiology involved, isn't there?
Yeah, I
That's-
fully agree.
Yeah, that's key actually in the world of mapping. That deep down, we need electrophysiology information.
But anyway, now you have sinus rhythm. So how will you continue? Will you do some line in the roof or in coronary sinus some ablation, or what will be strategy now?
So my strategy is to do nothing more. I'm going to check the veins and make sure they're isolated. But I'm a real believer that the more you do, the more substrate you create.
Yeah.
We've ablated him to sinus rhythm, so we've hit the substrate that's relevant on the day. And I think the likeliest reason for recurrence is either reconnection of the veins or failure of one of the lesions that I've done, the CFE. And I really don't want to add anything more to him now.
That's important to emphasize, that once you start to do some linear lesions, you have much higher risk that you will have recurrences not of atrial fibrillation but some regular atrial tachycardias. And these could be even worse tolerated than atrial fibrillation. So sometimes patients are really unhappy because they have 2-to-1 conduction, relatively rapid heartbeat that is regular. So they come back and they complain that they are even worse than before the ablation. So this is also now our strategy, not to ablate too much, or once you decide to do line, it has to be really line that is with block. So the least, let's say, attractive line for us is mitral isthmus line, because it is a very difficult area. And as I mentioned at the beginning, there is usually input from epicardium, from the area of Marshall vein. So in some cases, it's really difficult to ablate endocardially, even though you ablate in coronary sinus, but it's close to the valve and not usually in the area where you need to ablate in the area of Marshall vein. So this is important to emphasize here.
Yeah, so if we look at the signals now, guys, we can see that I've moved into the left pulmonary vein, and that's reconnected. So there is still a little bit of work to do to really get that completely isolated. The earliest PV is 5.6 probably.
Can we see
down at the
signals
bottom end.
now, please? Signals? Okay. Do you pace in CS to see better, or you just rely on sinus
Well,
rhythm?
I think now it's so late, isn't it, that
Yeah,
there's
yeah.
quite a clear distinction
Yeah,
between
yeah.
the far field and the local, but I don't think that's going to be necessary. So I'm just going to explore around the vein. I've put the mapping signal right next to 5.6 to allow me to time it without having to ask Neil, our gorgeous technician, to continually update the timings for me. And you can see as I come up the back wall here, the timing of the map appears to be getting relatively earlier. And that's clearly earlier than the left pulmonary vein signal.
If you look at the signal now from the pulmonary vein and you see the ablation or mapping catheter, it's quite early now.
Yeah.
So that's a mapping of the gap of conduction within the vein.
Do you look back at your VisiTech data to help you guide maybe where you might have left a gap?
I'm more driven by anatomy, to be honest, Andre, as I'm sure you are. You know that no matter the fact that we've got low VisiTag FTIs here, the anatomy is such that you'd be pretty disappointed if it had reconnected here. Whereas this sort of thick ridge of tissue here is always a culprit or a favorite for...
Can we see again the map to appreciate where you are now? Yeah. Okay.
So here I was late, and as I come up, it's been getting earlier, and I'm right on this ridge between the vein and the appendage. So I'm going to have a little go here, because I think with the eye of faith, I can sometimes see a little continuous signal there, bridging those two signals. I'm just going to see if I can just get the catheter position slightly better. You can see there's a little potential between the two. So let's see if I've got that right or I've misjudged the situation.
Interesting observation came out from our experience when we did studies with Endosens technology and remapped the patients after 3 months. And it came out that even if you measure contact force and you carefully apply these criteria that you have a reliable FTI, you still have some gaps that can occur, especially if you jump with catheter back and forth. So if you leave some areas like gaps and then you come back to this area later on. So in other words, it's better if you do isolation of pulmonary veins to start somewhere and go step by step around, not to start somewhere up and down and move from one area, one quadrant to another quadrant. So this was, of course, post-hoc analysis, but I think it has some relevance. Maybe you create edema if you apply somewhere, and then you cannot do successful ablation in the same spot if you come back later on. That's one explanation.
Joseph, I couldn't agree more. I think a drag lesion set is so much more likely to isolate on the first time round than an individual point lesion set.
Yeah.
I totally agree with you.
There is one question.
Hey, Richard, thanks. This is Haran speaking. Beautiful case, very impressive. I'm just asking you a question regarding the point that got you back into sinus rhythm. You didn't really map the atrium very much, so how come you chose that point? I can understand that you're looking for rapid firing, but how do you know where the fastest firing point is without really mapping the atrium?
So I was partly using the PV and CS signals. So as I mentioned before, it was CS distal to proximal. So I know it's unlikely to be coming from the posterior septum. I saw that the appendage signal was earlier than the CS distal, so it was more likely to be coming from anterior than somewhere between the CS and the appendage. And then I put my mapping catheter septal of the appendage, and I was then looking at the relative timing of the distal and proximal. And so I basically kept on dragging my mapping catheter back from lateral to septal until I no longer saw a gradient between the distal and proximal, suggesting that I got to the point where activation was not coming past the proximal electrode, but was going to the distal electrode. And going to the distal electrode, but was actually bridging or in the middle of those two electrodes. So that's how I got there. It was sequential mapping rather than a complete mapping. I just kept on going until I got as early as I could and then stopped.
Okay, so you can actually use this when there's a certain amount of organization in your atrial fibrillation. And what do you do before that really gets organized?
So if you're not organised, if it's complete chaos, then I agree. You go to the areas which you know are going to be the culprits, like the. Can you have an AP? Like the ridge between the veins, the septum, and you just have to do a complete map to see where the fastest signals are.
Any more questions or comments? Because it's already 1 hour. We have this transmission, so if you want to ask something, you have chance.
I think the whole audience is very impressed, stunned into silence.
Yeah, they are all stunned.
Very good.
So you have question, lady? You have question? No? There is question
One last
in
question
the
from the back.
Yeah, Professor Schilling, this is Majdi speaking. I want to ask you about when you finished isolation of the pulmonary veins, you went directly positioning the lateral catheter at the base of the appendage. Do you need sometimes to perform like cafe mapping first, or you don't go for cafe mapping at that stage?
So I would do the cafe map with my ablation catheter if, as we said, we had a sort of fairly fast and difficult activation sequence to map, you know, looking at activation timing. And I would generally just try and characterize the areas that were really fast and ablate them as I go along. So I'd look for those sort of type 1 electrograms that are really almost continuous and fast, and pick those off in every area of the atrium that I could find. I try and avoid the anterior wall wherever possible, or at least trying to do a lot of ablation on the anterior wall, simply because I know that that's the most contractile part, and I don't want to get rid of all their atrial transport. I don't use the pulmonary vein catheter for the CF EMAP because I think the electrograms you get from the pulmonary vein catheter are quite different from the mapping catheter. And I also just want to ablate signals that I'm interested in as I go along to try and keep the procedure as efficient and timely as possible.
Thank you.
Okay. There is no more question, or there is one. So,
okay, 2 more questions.
2 more questions, please.
Thank you very much for the case. Just building on the last question, as I understand, the reason why he went looking for earliest activation, where he eventually ablated and got him back to sinus rhythm, is because the cycle length was not that fast. So this is why he didn't look for rotors. Is there a cutoff point below which you would look for rotors, or is it just an impression? If you see it not that fast, you would go and target it, and if it is that fast, you would look for rotors?
Did you hear the question?
I did. It's a good question. So really the key is it's not the speed of the AF so much as the pattern recognition. So if you can see patterns in it, then you're in business. So let me try and give you an example. I'm just trying to show you the signals here. See if I can find a bit where you... I don't know whether you can see the signals on the bar, can you? Let me see if I can find a bit where we've got some mapping of the atrium. So here...
we have the BART signals enlarged, please.
So have that on the big.
Thank you.
So here you can see that it's clearly random, it's clearly irregular, but there is a pattern. So although the proximal does become earlier than distal occasionally, in the CS it's generally distal to proximal. generally the PV is faster than the CS, suggesting that it's whatever is driving the AF is closer to the PV. And we can see that the PV56 is the earliest PV. And when we were looking at the PV in the appendage, 5.6 was on the anterior aspect of the appendage. So I knew that whatever was fastest in that atrium had to be near the PV, on the anterior wall, not near the CS and the CS distal, and not near the CS proximal and the septum. So with that starting point, and because I could see patterns, I could then begin to try and find an area or go back earlier than PV56 until I couldn't get any earlier. If it's complete random chaos, you can't do that. So if you can't see a pattern, you can't see a generalizable appearance, you can't do that kind of mapping. And then you've just got to start to try and organize it either by giving a drug or by picking off the most chaotic and fast areas in the atria with CFE ablation. So it's not necessarily the speed, it's just being able to see a repetitive pattern within that chaos is the key.
Okay, one more question here.
Do you try to re-induce atrial fibrillation by pacing or excitation, or you are happy with the sinus rhythm and you discharge the patient on this?
I'm absolutely delighted with sinus rhythm. As you know, we can induce AF in anyone, and I really try and avoid getting myself drawn into doing a greater procedure than I've done already, because if I can get away and give him a good result with the amount of lesions we've done here, he's virtually got a normal atria now. The more ablation I do, the more I destroy his atria, the less quality of atrial tissue he has afterwards. So if I can get away with this, I'm really delighted with that. And I don't want to draw myself into doing more damage that could be pro-arrhythmic.
Thank you.
Okay, any more questions? If not, I think it was a great case. We learned